Welcome to week 4, part 1, hemodynamic monitoring. We're going to discuss arterial blood pressure monitoring and pulmonary arterial pressure monitoring. All hemodynamic monitoring is done in an ICU setting or a critical care unit. Hemodynamic monitoring is invasive, and it's an invasive measurement of pressure, flow, and oxygenation within the cardiovascular system. In order to understand hemodynamic monitoring, you must have a good understanding of cardiac output. And so I'm going to review this. Again, I know you've done this in other courses, but I just want to give a quick review. So this is must-know terminology. So what is cardiac output? It's the amount of blood that the heart pumps within each minute. And so it's normally about 4 to 8 liters a minute. It's comprised of heart rate and stroke volume. So heart rate times stroke volume equals cardiac output. So heart rate, as we know, affects your cardiac output. And we learned that last class when we spoke about different arrhythmias, sinus bradycardia, sinus tachycardia, and how it affects the cardiac output. Stroke volume is the amount of blood ejected from the heart with each contraction. And it's comprised of 3 important components: preload, afterload, and contractility. And if you look at any of the cardiac meds, they are all based on either a heart rate or stroke volume. They're going to affect one of those 2 things to increase the cardiac output. So we think about preload. Preload is the amount of blood, preload is the amount of blood that's returning to the heart that the heart must then manage. So it's also known as the left ventricular end diastolic pressure, and it's the amount of stretch that the ventricle has at the end of diastole. So end of diastole is the filling part of the left ventricle. And so a lot of analogies think about it as a balloon. And so think of it as the heart loading up for the next big squeeze of the ventricles during systole. And so if you think of the analogy of the balloon, blow air into the balloon. As it stretches, the more air you blow in, the greater the stretch, and then the greater the contraction. Afterload is the pressure that the left ventricle must exert to get the blood out of the heart and into the aorta. The higher the afterload, the harder it is for the heart to eject blood, thus lowering the stroke volume. Afterload is also known as systemic vascular resistance, so the amount of resistance that the heart must overcome to open the aortic valve and push the blood volume out into the systemic circulation. So if you think of the balloon analogy, afterload is represented by a knot at the end of the balloon. And so to get the air out, the balloon must work against the knot. And I often think about afterload and systemic vascular resistance as hypertension. So hypertension causes the walls of the arteries to be constricted. And so if we can relax those arteries, relax the pressure in those arteries, it makes the heart easier to pump out against that resistance. So think of hypertension as a resistance. And then contractility is the strength of the contraction. And so again, there are many different cardiac meds that we give to improve different areas of the cardiac output. So how would you assess your patient for decreased cardiac output? So from the previous definition, we know decreased cardiac output is inadequate blood pumped by the heart to meet the metabolic demands of the body. So not enough blood is getting out to the other organs. So first of all, how do we recognize it? And so I like to do a head to toe. So when I think of decreased cardiac output to my brain, I think of decreased level of consciousness. I think of irritability. I think of anxiety, restlessness. For cardiovascular, if you have a decreased amount of blood circulating within the heart, you may have angina. You may have low blood pressure, hypotension. The heart may be rapidly trying to beat faster to get the blood out to the other organs. So you have tachycardia. In the peripheral system, your pulses could be decreased because of decreased cardiac output, decreased perfusion. You could have cold, clammy skin, poor cap refill, and the patient will feel of a decreased activity and decreased activity tolerance and fatigue. If I think of the respiratory system, I think that the heart is not pumping well enough, and so you're having a backflow of blood back into the lungs. Remember, the heart and lungs work together. So you may have crackles, shortness of breath, Orthopnea, meaning you can't lie flat. You may have an increased heart rate, so tachy, and decreased oxygen saturation. Renal, if you're not getting enough blood out to the kidneys, this is the great sign for the kidneys is decreased urine output. They're just not getting enough blood out to function properly, and so they have a decreased urine output. And the other would be because of poor circulation, you would have a weight gain and edema. So these are some of the findings that signs and symptoms you will see with your patient. So let's look at arterial lines. So arterial lines are continuous arterial pressure monitoring via a percutaneous, so through the skin, introduction of a catheter into the radial, brachial, or femoral artery. Why monitor the arterial blood pressure? Well, continuous arterial pressure monitoring is indicated for patients experiencing acute hypertension or hypotension. So you really want to be able to monitor the blood pressure very closely. In those patients who have respiratory failure, because you're going to be obtaining your arterial blood gases from your arterial line, shock, neurological injury, anyone going for an interventional procedure, for a coronary interventional procedure. If you're giving any type of vasoactive drugs, that you need to have a good feel for where the blood pressure is at. And again, for frequent arterial blood gas sampling. So typically anyone who's very sick and needs close monitoring of their blood pressure and obtaining samples for arterial blood gases, they're going to have an ART line or an arterial blood pressure line. So in order to do this test, you need to make sure you have good circulation in both the radial and the ulnar artery, because once this ART line is placed into the radial artery, the flow is not as good as before. And so you always do the Allen's test to make sure that the ulnar artery can pick up any slack from the hand. And so two arteries supply blood to your hand. One is the radial artery and one is the ulnar artery. So you need to assess for adequate, and the respiratory therapist will do this. They are typically the individuals that are putting in ART lines. So you need to assess for adequate collateral blood flow to the hand, and this is done by the modified Allen's test. Ask the patient to make a fist, then occlude the patient's ulnar and the radial arteries with both thumbs. So this is in the left. As the patient, so their hand is going to start to blanch because you're holding it. As the patient releases the fist, the hand should be pale. Release the pressure of the ulnar artery. So you're going to release the pressure. In a negative test, the hand turns pink, which indicates that the ulnar artery is properly functioning. Therefore, one can proceed with the arterial line placement in the radial artery of that hand. So why they call it a negative test is odd, but basically in some texts call it a positive test. So what you want to see is that the ulnar artery is actually perfusing the hand. I don't understand why they call it a negative versus a positive test, but what you're looking for is that you've got good perfusion. When you release the pressure from the ulnar artery and you continue to occlude the radial artery, that you have good blood flow. So typically the arterial setup is this. Up here you will have a saline bag, which is under pressure. So you're going to wrap, it's almost like a blood pressure cuff around this pressure bag, because remember the arterial system is very high pressure. And so it's the system that's pumping all the blood throughout the body. So it's going to be under pressure. So you need to have a pressure bag in order so you don't get constant blood flow back into your line. It's connected to this three-way stopcock, which allows you to turn this lever or switch when you want to turn it off or on to obtain some blood. So for your blood gases. You're going to have a transducer that goes to a monitor, and then you're going to have this pressure tubing here that goes along here. You have another stopcock here for measuring specimen collection. So some have two, some have one, but this is basically what your setup is for your arterial line. You always have a blood pressure or a pressure bag. You always have a monitor. You always have this pressure tubing with a stopcock. And the transducer is what sends the signal of the blood pressure to your monitor. So this is what your arterial line tracing looks like. This is your arterial line here, and you can see that it corresponds to the 12-lead ECG. And so the QRS responds to this arterial waveform, and this is your blood pressure every time. And so if I look at this patient's blood pressure, this patient is ranging around, I think that's a 160. 160 over 60 is their arterial blood pressure. So you've got contraction and then blood pressure. So what are the complications? So obviously infection, hemorrhage, you could for sure bleed from there. A thrombus, you could have a thrombus formation or a clot develop. And neurovascular compromise, as I've talked about, the importance of the circulation to the hand. So nursing care, you're going to be assessing the system every 1 to 2 hours. You want to make sure the pressure bag is under 300 millimeters of mercury. You're constantly looking at the fluid level of the pressure bag to make sure there's enough fluid in there to exert enough pressure. The patency of the line. You're going to be monitoring for complications, so your neurovascular status, so your 5 Ps, pain, pulse, pallor, paresthesia, and paralysis of the hand. Your CSM, so your circulation, sensation, motion is another way to assess the status of that hand, and then cap refill. So moving on to pulmonary artery catheter. So this is an invasive heart catheter that's used to measure different areas of the heart. So it can measure the right arterial pressure, which is the right side of the heart, and we call this your central venous pressure. It can monitor the left side of the heart, which is the pulmonary artery wedge pressure, and then it can monitor the pulmonary artery pressure. So it's monitoring the right side of the heart, the left side of the heart, and the pulmonary artery pressure. 3 different areas. Typically, it's in the neck, and so it's kind of a similar setup to your arterial line, just a little bit longer of a line and some different ports here that you can actually infuse medications through. It's kind of a busy looking system, but it actually makes sense. And so this is all outside of the body, and these are all inside of the body. And these are really important markers to make sure that when you're inserting when the physician is inserting the PA catheter, that they can look at the markings and get an understanding of actually where they are when they are threading this system or this tube through here, or this catheter through. And so there's a balloon inflation port that's important. You can actually, there's a thermostat port, which is required when you're actually measuring cardiac output. But these are the ports that are important for you when I was talking about the right atrial pressure. And so this port here, the blue port, will be connected to a monitor, and it'll measure your right atrial pressure. So that gives you an understanding of whether the patient's dehydrated or not dehydrated, or what their blood volume is like, because it's measuring the venous return coming back into the heart. And your distal port, which is over at the end over here, is going to be measuring the left ventricular and the pulmonary system. And then other ports can actually give fluids and medication. So where is it inserted? And so it's a catheter with a balloon tip, and it's inserted into a vein. So it's not an artery, it's inserted into a vein, typically into the internal jugular vein or the subclavian vein. And it's advanced through the superior vena cava into the right atrium and ventricle, then into the pulmonary artery. And I'm going to show you another picture. The catheter is guided further until the balloon is inflated. And when the balloon is inflated, it's kind of wedged into the distal artery of the pulmonary, distal branch of the pulmonary artery. And it almost looks as a camera into the pulmonary system. Now, the balloon is only inflated when you want to have that peak into the pulmonary system. Otherwise, it's left deflated. So again, this is the tube going into the jugular, and you can see it's very long. It goes down here, it goes through the superior vena cava into the right atrium, through the valve here, across the other valve here, and it kind of sits right here in the pulmonary artery. And so it can get a sense of what's happening in the pulmonary system. It can kind of look back and see what's happening in the ventricular system. And it can also, this port over here can monitor the right atrium. So it really does give an overall monitoring of the cardiac system, including what's happening in the respiratory system. So this is just another example. This is an advanced skill. You don't just walk in as a new grad and start taking care of PA catheters. You need to be working in the intensive care unit for a good year, and you have to do a lot of extra education to be able to be a nurse who monitors these catheters. So again, you've got the different ports. It's threaded through the superior vena cava, the right atrium. So the proximal port right here is a little camera right here that measures what's happening in the right atrium. So it's measuring all the blood that's coming back into the right atrium. So if you're dehydrated or a low blood volume, it's going to pick up on that. Then it's threaded through this valve and then this valve into where it sits here in the pulmonary artery. And it just sits there. And the only time that the balloon is inflated is when you want to take a peek of what's happening in the lungs and kind of what's happening over here. Remember, the blood comes from the right ventricle into the pulmonary system, and then into the lungs, and then it comes back into the left side of the heart after it goes through its exchange of oxygen and carbon dioxide in the lungs. And so this system is sitting just as it comes out of the right ventricle. It sits here. When you inflate this balloon, it gives a look into what's happening in the lungs and what's kind of happening over in the other side of the heart in the left atrium and the left ventricle. It's kind of crazy. And so it can kind of get an understanding of how this left ventricle is functioning. So this is a really, it's a better schematic diagram of what it's actually looking at compared to the previous one. And so these are the different waveforms. And so as the physician is putting the catheter through and you've got the catheter connected to your monitor, you're going to see these different waveforms, and that's how the physician understands where they're at as they're advancing it. So the right atrium is going to have this very, remember, it's a low pressure system, the right atrium. So it's going to have a very low pressure reading. Then it goes into the right ventricle, and you can see a high pressure. Then it goes into the pulmonary artery, and then your pulmonary wedge pressures. This is really important to understand these pressures, because if for some reason this catheter migrates back out of this pulmonary artery tracing, so I know as an ICU nurse that this is what the tracing should always look like. If it becomes a very big tracing like this, then I know that this catheter has slipped back into the right ventricle. The only time you're going to be using this, the only time you're going to see this rhythm is when you actually have the balloon inflated and it's looking forward into the lungs and the left side of the heart. Otherwise, it's always going to be this tracing. So what's the purpose of it? Well, the PA catheter yields information about the client's cardiovascular status, so their circulatory status. It gives an understanding of the left ventricular pumping action, how much blood is coming back in to fill the heart, and the tone, the vascular tone, meaning the afterload. It allows for micromanagement of fluid volume problems and cardiac function. So you can really micromanage how much fluid you're giving to this patient, because you can physically see the pressures in the heart. So where is it used most? It's used most if someone's in heart failure, where they have fluid overload, so congestive heart failure, to kind of figure out how much diuretics to give, and whether you're getting that fluid overload under control with certain drugs, and also for a fluid volume deficit to know how much fluid to give in order to bring that fluid volume back to the correct state. So these are the normal pressure readings, and this is really what you need to know for this course, is just to understand the pressure readings. So your right atrial pressure or your central venous pressure is anywhere from 2 to 8 millimeters per mercury. If it's under 2, that means you have a low blood volume. If it's greater than 8, you're in fluid overload. So remember I said part of the monitoring system is monitoring the right side of the heart, so that venous return. So this gives you an understanding of your blood volume. Your pulmonary artery wedge pressure is looking into the pulmonary system and the left side of the heart. And again, it's looking to see, is the patient in heart failure? Is there a fluid overload? And so if the normal is between 6 to 8 millimeters per mercury. So if it's under 6, there's a low blood volume. If it's greater than 12, the patient's in fluid overload. And then lastly, the pulmonary artery pressures is more to look at the pulmonary system. So what's happening on that side? So you may have an individual that has a left to right shunt. So maybe they have an opening between the left and right ventricle and blood is shunting back. So it may be used for if someone has pulmonary artery hypertension, your COPDs and your emphysemas, anyone who has pulmonary embolism, pulmonary edema, or left ventricular failure. So remember, the pulmonary system and the left side of the heart work hand in hand. So nursing care, what are you going to be involved in? Well, you're going to assist the physician with catheter insertion into typically the jugular or the subclavian vein. Very rarely does it go into the femoral unless there's been some type of trauma and it can't be inserted in the neck area. Very important that a chest x-ray is going to be obtained afterwards to verify the placement and make sure that there hasn't been any complications specifically of a pneumothorax. You're going to be constantly observing the site for inflammation and providing site care, changing the dressing as per protocol, observing the line for patency and air bubbles. Important to notify the physician if the waveform changes or pressure readings are altered. So remember I talked about those different waveforms? And important that the balloon does not remain inflated after the wedge pressure determination. So when you're doing your wedge pressure, your pulmonary artery wedge pressure, you actually inflate this balloon that travels a little bit further into the respiratory system or the lungs, and it takes that snapshot of what's happening. You do not want to leave that balloon inflated. And so once you do your reading, and it is really less than 30 seconds, the balloon is deflated and everything goes back to normal. You do not want to leave that balloon inflated. And then just as an additional note, you remember that this is just one other way to monitor your heart, that it's not it's not by any means the only way to measure how your patient is doing. So single hemodynamic values are rarely significant. The nurse must evaluate the whole clinical picture with the goals of recognizing early clues and intervening before problems escalate. And so some of the things that you'll be looking at is the patient's general appearance, their level of consciousness, skin color, temperature, vital signs, peripheral pulses, urine output. And so very important to look at the whole picture. And then what are some of the complications? Well, when when the physician is inserting the pulmonary line or the catheter, you can get ventricular arrhythmias, or if this catheter falls back into the right ventricle, you can get arrhythmias. It just causes irritability. It could cause an inflammation and endocarditis of the inner lining of the heart. It may cause valvular damage because it's that catheter is going through those valves. You could have a cardiac rupture, a cardiac tamponade, where there is some type of puncture and the outer part, the encasing of the heart fills with blood and it compresses on the heart. You could have pulmonary artery thrombosis because of where the catheter is lying, and a lung infarction. So it's not by any means a benign, it's very invasive. So I'm just going to end off with this video to give you just a final overview of the PA catheter.
In this video, we will discuss about the pulmonary artery catheter, also known as Swan-Ganz catheter. A Swan-Ganz catheter is usually 110 cm in length. A balloon surrounds the tip of the catheter. Catheter is marked at 10 cm increments from the tip, to aid insertion. Usually there are 4 ports in the PA catheter. First is the proximal infusion port. Its lumen terminates 30 cm from the tip of the catheter. This opening lies in the right atrium when the tip is in the pulmonary artery. So this port can monitor right atrial pressures, that is central venous pressure. It can also be used to give fluids and drugs. The second is the distal pulmonary artery port. Its lumen terminates at the tip of the catheter. So when in position, this port is used to measure pulmonary artery pressure and mixed venous saturation. Third is the balloon inflation port. Fourth is the thermistor. Its lumen terminates 4 cm proximal to the tip of the catheter. It is used to measure cardiac output using thermodilution technique. The catheter which we are going to see does not have the thermistor. The PA catheter has to be flushed with saline before the insertion. So when the distal pulmonary artery port is flushed, the saline comes out of the tip of the catheter. Next, the proximal infusion port is flushed. One can see the saline coming out of the opening at the 30 cm mark, as discussed earlier. The balloon of the catheter is checked by inflating 1.5 ml of air using the syringe as shown. The balloon is used to guide the catheter into pulmonary artery by the balloon flotation technique. The balloon is also used to wedge the pulmonary artery to measure the pulmonary capillary wedge pressure, which is an indirect measurement of left atrial pressure. PA catheter is inserted after placing an introducer sheath in the internal jugular vein. The side port of the introducer sheath can be used for rapid infusion of fluids. Let's open up the heart to see the position of the PA catheter in relation to the internal anatomy of the heart. Pulmonary artery catheter is then gradually inserted into the sheath. It should be noted that a pressure monitoring transducer is attached to the distal pulmonary artery port to observe the continuous pressure waveforms. Once catheter is inserted till 20 cm mark, it usually crosses the tip of the insertion sheath. Now the balloon of the catheter is inflated with 1.5 ml of air. So now the tip of catheter floats in the blood and aids in the correct placement of the catheter. The catheter is advanced till the right atrial pressure is obtained in the monitor. In the right atrium, the pressure usually averages less than 5 mm mercury and fluctuates between few millimeters mercury. When pushed further, it reaches the right ventricle. The systolic pressure increases to about 25 mm mercury, and diastolic pressure remains same as the right atrial diastole pressure. When the catheter tip reaches the pulmonary artery, the systolic pressure is similar to the right ventricular systolic pressure, but there is increase in the diastolic pressure, to about 10 mm mercury. It is due to the closure of the pulmonary valve during diastole. When the catheter is pushed further into one of the branch pulmonary artery, the balloon wedges, and it measures indirectly the left atrial pressure. The mean pressure is about 10 mm mercury, and the waveform is similar to that of right atrial pressure. Once the wedge trace is obtained, the balloon is deflated, and return of pulmonary artery pressure trace is confirmed. If the PA trace is not obtained, the catheter is withdrawn slightly, till the PA trace appears. Usually the right atrium is entered at 25 cm, the right ventricle at 30 cm, and the pulmonary artery at 40 cm. The wedge pressure can be identified at 45 cm. These are only approximate measurements. Once the procedure is complete, Chest X-ray is taken, to check the position of the pulmonary artery catheter. Hope this video was helpful. If it is, please do share it.
Okay, just kind of gives you a kind of a different overview of how it's inserted, which I thought was important, and just kind of a schematic diagram of the heart of where how it travels through. So bring your questions to our Zoom class, and up next we will be talking about different central venous devices, and then we will do a review of arterial blood gas interpretation. Thanks.